السلام عليكم.
وعليكم السلام دكتور.
Okay, guys, today, inshallah, we will continue the curriculum. As usual, 1 minute for new members. The exam is 2 papers, each paper 2 hours, and 1 hour break in between. Again, you can find in the exam clinical questions, non-clinical questions, medico-legal questions, and also regarding the clinical, they can ask you about relevant basic sciences, relevant epidemiology, differential diagnosis, investigation, and the management of these conditions. You have to follow the curriculum of the Royal College. The curriculum is 31 chapters, and you have to follow the blueprint. The blueprint is the distribution of marks, distribution of questions. So which category you will focus on and so on. So again, regarding the clinical questions, you have 5 important chapters. Don't go the exam without these chapters. Memorize like your name. Resuscitation, cardiology, trauma, pediatric, anesthesia. Okay, so anything related to anesthesia, it's very, very important. Anything related to pediatric, anything related to cardiology, related to trauma and resuscitation. So the curriculum from resus up to safeguarding and psychosocial emergencies in children. Resus we finished already. Allergy, cardiology we finished. Dermatology, ENT, elderly care and frailty, endocrinology, environmental emergencies, gastroenterology and hepatology, hematology, infectious disease, maxillofacial, mental, musculoskeletal, neonatal, nephrology, neurology, obstetric and gynecology, oncological emergencies we finished, ophthalmology, pain and sedation, and today, palliative and end-of-life care. It's a very short chapter and also a very short session. So the presentation here, they can give you scenario for advanced malignancy and end-stage chronic disease. So the patient is about to die. We are talking about patient is going to die. Okay, so what you will do with this patient? Maybe he will die within 1 hour, within 1 day, within 1 month, within 1 year. So this patient needs special care. Okay, and already he understand or his family understand that he's going to die. Okay, but he's stable at the moment. The patient is stable at the moment. Okay, so condition and issues, advanced care planning, anticipatory medications, end stage organ failure, especially renal, kidney, pain management, physical symptoms other than pain. So here, one of the most important point in patient going to die, to manage his pain, okay, and also manage other symptoms rather than pain. For example, nausea, vomiting, agitation, anxiety, any symptom other than pain. Psychosocial concerns, including spiritual care and care of the family. So you have to care about the patient and care about the family as well. The dying patient. So we are talking today about patient is very old and he has advanced malignancy or advanced liver disease or kidney disease, and he's going to die. So, what end of life care involves? Who provides end of life care? What is palliative care? Who provides palliative care? When does end of life care begin? Okay, so we will discuss these issues. Okay, so what end of life care involves? End of life care is support for people who are in the last months or years of their life. So going to die here, it doesn't mean within minutes or within hours. Okay, it can be last months or years. End of life care should help the dying patient to live as well as possible until he dies and to die with dignity. So the aim here for patients who are going to die with dignity. So you have to care about those patients, and here you have to support them whatever in the hospital or at home. The one who decides the patient, which place, so it will be decided by the patient. The people providing his care should ask him about his wishes, preferences, and take this into account as they work with him to plan his care. They should also support his family, carers, and other people who are important to him. Patient has the right to express his wishes about where he would like to receive care and where he wants to die. Patient can receive end-of-life care at home or in care homes, hospices, or hospitals, depending on his needs and preference. So this patient needs hospital, it will be in hospital. No need for hospital. If he wants to be at home, it can be at home. Okay. Who provides end-of-life care? So different health and social care professionals may be involved in his end-of-life care depending on his needs. For example, hospital doctors and the nurses, GP, community nurses, hospice staff, and counselor may also be involved, as well as social care staff, chaplains of all faiths or none, physiotherapist, occupational therapist, or complementary service. So it means any staff related or needed by the care of the patient. So you can expect any staff. If patient is being cared for at home or in care home, so HGB has overall responsibility for his care. So community nurses usually visit him at home, and the family and friends may be closely involved in caring for him too. What is palliative care? So end-of-life care includes palliative care if patient has an illness that cannot be cured. Palliative care makes him as comfortable as possible. So his disease is not curative and he's going to die. So you have to talk about palliative care. It means you will make the patient comfortable as possible by managing his pain and other distressing symptoms. This is the meaning of palliative care. Involve psychological, social, spiritual support for him and his family or carers. This is called holistic approach because it deals with you as whole person, not just an illness. Okay, so you have to deal with the disease as whole person. So you will deal with the disease, with the person, with the family, with the carer, and everything. Palliative care is not just for the end of life. He may receive palliative care earlier in his illness, while he is still receiving other therapies to treat his condition. Who provides palliative care? Many healthcare professionals provide palliative care as part of their jobs, like GP or community nurses. Some people need additional specialist palliative care? So any point can be a question. Any point can be a question. So just be familiar with each point. Some people need additional specialist palliative care. This may be provided by consultants trained in palliative medicine, specialist palliative care nurses, specialist occupational therapists, or physiotherapists. When does end of life care begin? End of life care should begin when patient needs it and may last a few days or few months or years. People in lots of different situations can benefit from end of life care. Some of them may be expected to die within the next few hours or days. Others receive end of life care over many months. People are considered to be approaching the end of life when they are likely to die within the next 12 months. So, when to say this patient is at end of life care, so when you are expecting the patient will die within 12 months. So he needs end of life care. Okay. This includes the people whose this is imminent, as well as people who have an advanced incurable illness, such as cancer, dementia, or motor neuron disease, are generally frail and have coexisting conditions that mean they are expected to die within 12 months. Have existing conditions if they are at risk of dying from sudden crisis in their condition. Have life-threatening acute condition caused by sudden catastrophic event such as accident or stroke. The National Institute for Health and Care Excellence, so NICE, has published guidance on the care of dying adults in the last days of life. This guidance covers how to manage common symptoms as well as dignity and respect for the dying person, their relative, and the carers. So the most important to manage symptoms, to keep dignity and respect for dying person, their relatives, and the carers. I sent the PDF. I sent two PDF for this chapter in the group and in the channel, so you can read that. Presentation number one, advanced malignancy and end-stage chronic disease. So spinal metastasis. So this is common problem in dying patient. So the most important here, neuropathic pain as a consequence of a spinal metastasis, whatever the patient has a primary prostate or breast female lung malignancy. So after that, he has a spinal metastasis. After that, he has neuropathic pain. So they can ask you in the exam about this issue, about this scenario. So here the patient is going to die within 12 months, and he has history of prostate cancer, and he has now neuropathic pain. So it means he's talking about advanced malignancy and end-stage chronic disease. So the initial treatment for neuropathic pain, be familiar with amitriptyline, duloxetine, gabapentin, pregabalin. So if you find any of them in the scenario, you can choose. What about tramadol? Should only be considered if acute rescue therapy is needed. Esophageal candidiasis. So this is another scenario most commonly seen in patients receiving treatment for hematopoietic or lymphatic malignancies. So any patient with old age and expected to die within 12 months, and he has dysphagia or adenophagia, so think about esophageal candidiasis, and the classic combination of symptoms in esophageal candidiasis, dysphagia, adenophagia, retrosternal pain, can be life-threatening infection and often requires hospital admission. This one don't treat at home. This one needs hospital admission. Treatment. So first line, be familiar with first line and second line. Oral fluconazole, 200 up to 400 milligram daily. If oral treatment cannot be tolerated, so you can go for IV fluconazole. The second line, oral itraconazole, oral osaconazole, or IV or oral voriconazole. Advanced care planning. So we discussed before about advanced directive and lasting power of attorney. So you have to be familiar with advanced directive, when it will be valid and when it's not valid, and also lasting power of attorney, when is it valid, when it's not valid. Okay. So advanced decision, here the patient will document paper, so should be signed, should be written, should be documented, should be witnessed by two witnesses, and the patient should be adult. The patient should state that he doesn't want to receive in the future specific management. Okay? Whatever this management is, CPR, or in case if he has trauma, or in case if he has he needs resuscitation. So whatever, you have to check validity. Legally binding document that allows the convenience of decisions regarding end-of-life care ahead of time. They provide means of communication for patients' own wishes, helping to clarify this with healthcare professionals and family members. If a patient loses the capacity to make an informed decision regarding their care at a late stage in their illness, advanced directive can help to avoid confusion. So any patient who have advanced directive, it's not valid if the patient has capacity. Okay, any patient who have advanced directive, you should apply if he has no capacity at the moment. Okay, so if a patient loses the capacity to make an informed decision at the moment regarding their care at late stage in their illness, advanced directive can help to avoid confusion. The GMC advised that in cases where there is serious difference of opinion between yourself and the patient, within the healthcare team, or between the team and those close to a patient that lacks capacity, you should seek advice or second opinion from a colleague with relevant experience. Remember that it can be a question. In this case, it would be prudent to seek advice from palliative care specialist. Remember that also it can be a question to resolve this disagreement between yourself and the patient's wife or relative. Advanced decision or advanced directive in Scotland, a statement of patient's wish to refuse a particular type of medical treatment. It should be specific to specific management. Particular type of medical treatment or care if they become unable to make or communicate decisions for themselves. They provide means of communication for a patient's own wishes, helping to clarify this with healthcare professional and family members. So we mentioned that already. So typically advanced decision can be used for the following. So it will be applied in these scenarios or these situations. So each point can be scenario. So he went to check for advanced decision in scenario of CPR. So the patient needs CPR. You want to continue CPR or not? So you have to check for advanced decision or advanced directive. So remember that CPR. To make decisions about the use of IV fluids and parenteral nutrition, the patient needs IV fluids and parenteral nutrition. We are talking about patient is going to die within 12 months. These conditions applicable for the patient is going to die within 12 months. Okay, our chapter today. So you need to give him CPR, you need to give him IV fluids, parenteral nutrition, so this patient has advanced decision or not. To make decision about specific procedures, you want to do any procedure for him, so he has advanced directive or not. To make decisions about the use of blood products. Okay, so Java witness. So this one, it can be a question. Each point can be a question. So here you have to check if the patient has advanced directive or not. And remember four conditions. Advanced decisions have limitations and cannot be used in the following circumstances. Okay, so to award a relative lasting power of attorney. So if the patient has advanced decision and he did lasting power of attorney for any relative, so the last one should be considered. So if the patient did advance a decision 4 months back and he did lasting power of attorney last month, so you consider the last one. To choose a spokesperson to make decision on the patient's behalf, to ask for specific medical treatment, to request something illegal like assisted suicide, to refuse treatment for mental health condition, to carry out treatments that are not in the patient's best interest. So remember these limitations, okay? So cannot be used. Advanced decision have limitation. It means cannot be used in the following situations. It can be a question, okay? So if you find any of them in the scenario, it means it's not considered. Doctor has a legal obligation to follow an advanced decision unless it changes are made which invalidate the decision. So any patient who has advanced decision, it will be not valid if it changes are made which invalidates the decision. It means the patient has advanced decision, for example, 4 months back, and today or yesterday he changed his mind. So it's not valid. There have been advances or changes in treatment which alter circumstances. So maybe he changed the decision in the advanced directive, so it means it's not valid for this circumstance. There is ambiguity in the wording of the decision, unsigned, so no signature on the document. So any document in our life should be signature, so should be witnessed, should be written to be valid. So unsigned or honesty is in doubt. If there are any doubts about the validity of the decision, legal advice should be sought. Okay, so remember that it can be a question. If advanced decisions have been forged or signed under duress, and any suspicion of this should be raised. So if they mention in the scenario, there is doubt regarding the decision, and there is doubt it's signed under duress. So here you have to raise suspicion. There is no specific time period for which advanced decision is valid. Remember that. It's common for people to experience symptoms towards the end of life. So we are talking about condition number 2, anticipatory medications. It means this patient is going to die, okay, and you are expecting he will get symptoms. Any patient is going to die within 12 months. It means you are expecting he will get symptoms like what? Pain, anxiety, distress, delirium, breathlessness, agitation, nausea, vomiting, noisy chest secretions, massive hemorrhage, bleeding, seizure. So at any time, you have to inform the patient he will get any of these symptoms. You have to inform the family he can get any of these symptoms. So you are expecting, okay? So you have also to prepare your medicine with the patient and also prepare the medicine with family. It's common for people to experience symptoms towards the end of life. including anxiety, pain, nausea, vomiting, nauseous secretions. These symptoms can affect people with many different terminal illnesses and can be very distressing. Medicines to help with these symptoms can be prescribed in advance. So you can give the patient these prescriptions even the patient doesn't have. So you can give in advance to make sure they are ready when needed. This can help people to feel as comfortable as possible towards the end of their life. If you will inform the patient, if you have headache, you have painkiller. If you have nausea or vomiting, you have this medicine to prevent nausea or vomiting. So at least he will feel comfortable. Okay. Clear instruction for giving each medicine must be written. So don't give him the medicine without instruction. No, you have to inform him about details, when to use, how to use, and blah, blah, blah. Clear instructions for giving each medicine must be written in the community medication administration chart, including dose, route, administration frequency, indications, limits, and when to ask for help. So also you have to document these things in record. Common anticipatory medicines include the following. So each point can be a scenario. So patient is going to die within 12 months, whatever, within 1 hour, within 1 day, within 1 month, within 12 months. So we can say within 12 months. So if the patient will get pain, so you can give him appropriate opioid, for example, morphine, diamorphine, oxycodone, or fentanyl. Medicine for breathlessness. So if you find in the scenario pain, think about opioid. If you find in the scenario patient has breathlessness, think about midazolam and or opioid. So opioid here for pain and breathlessness. Remember that. Medicine for anxiety, midazolam. So midazolam here for breathlessness and anxiety. Medicine for delirium or agitation, so haloperidol. Okay. Midazolam inverted. Medicine for nausea and vomiting. So think about cyclizine, metoclopramide, haloperidol, and levomeprazole. So noisy chest secretions, hyoscine, hydrobromine, glycopyrronium. So here the patient, if you find noisy chest, think about hyoscine. Any symptom, think about its medicine. Some of the medicines can help more than one symptom. So as we said, maybe opioid can help in pain and breathlessness. Midazolam can help in breathlessness and anxiety. So each medicine can help in more than one symptom. End stage organ failure. So most likely advanced kidney disease. Any patient with end of life, so most likely he has chronic kidney disease or liver disease, but here we will talk about a clinical pathway for management of advanced kidney disease. So the patient, you will plan for referral. Here, plan, you have to talk with the patient. He will take management at home, management at hospital. This management will be conservative or dialysis. So you have to share with the patient and also need to the patient. Maybe the patient needs dialysis. Okay, so here it's not about a choice. But if the patient can live with conservative, so you have to ask the patient. Choose. So unplanned referral, here assessment, you will assess the patient, what he needs exactly, needs a conservative or a dialysis. Education modality choice, so whatever conservative or dialysis, you have to educate the patient. Modality preparation. So here you have two options, and of course the definitive option, transplantation. So conservative management may be peritoneal dialysis or hemodialysis, and of course the definitive is transplantation. So you have to discuss everything with the patient and share decision with the patient. The end of life care pathway. So you have 6 points. Discussion as end of life approaches, assessment, care planning and review, coordination of care, delivery of high quality services, care in the last days of life, care after this. Even you are expecting the patient will die, so you have to prepare care after this. So you have to prepare everything with the patient or with the family. Everything should be ready, even papers. The end of life care pathway we discussed already, but we will discuss in more details. So 6 steps. The first step, discussion as end of life approaches. Guys, can you hear me clearly?
Yes.
Yes.
Okay. So open, honest communication. You have to talk with the patient honestly. Don't hide any information. You have to be clear with him. You have to be honest with him. Identifying triggers for discussion. Step 2, assessment, care planning, and review. So agreed care plan and regular review of needs and the preference. So you have to discuss with the patient. He needs blah, 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 whatever conservative. He needs dialysis, whatever peritoneal or hemodialysis. He needs a transplantation or whatever. You have to agree a plan, okay, and should be shared with the patient. Assessing the needs of carers, also who will care for the patient, and you have to share with the carer, whatever the relative or a friend or carer, so you have to share with them also. Coordination of care, strategic coordination, so whatever the patient will need, so if needs conservative, so you have to coordinate with the team for conservative. If the patient needs dialysis or whatever transplantation, so anything the patient needs in the end of life, so you have to coordinate according to the team. So coordination of individual patient care, rapid response services. Step 4, delivery of high quality services. So high quality care provision in all settings. So you have to give the patient the highest care, whatever, in home, in hospital, or whatever. So you give him the highest quality of care. Hospitals, community, care homes, extra care housing, hospices, community hospitals, poison secure hospitals and hostels, ambulance services. So you have to be familiar with each team, with each staff. He should be in contact with the patient at any stage. Step 5, care in the last days of life. So identification of the dying phase. So for example, you are expecting this patient will die after 1 hour. So you have to be familiar with that. You are expecting the patient will die after 1 month. You have to be familiar with that. He can die after 12 months. You have to be familiar with that. So you should identify the dying phase. Of course, no one can expect the dying phase, but at least you assess the patient regularly, regular assessment. That's why in step 2, agreed care plan and regular review of needs. So according to regular reviews, you can identify the dying phase. Review of needs and the preferences for place of death. Okay, so the patient want to die at home, want to die at hospital, want to die which city. So you have to share this with the patient as well. Okay, support for both patient and the carer. So you have to involve the patient and the carer as well. Recognition of wishes. So you have to ask the patient clearly, be honest with the patient, what do you want, what do you wish. So also the patient, uh, any wishes. So maybe the patient also he has wishes for organ transplant, but he cannot donate. So you have also to ask, even he is not eligible for donation. He has in the stage organ failures, okay, maybe multiple organ failures, but he wish to donate. So at least to consider what he wants, what is his wish, okay, even it's not eligible. Recognition of wishes regarding resuscitation and organ donation, okay, even it's not eligible. Maybe the patient needs resuscitation. He will ask you, I want you to save my life, even in it's not eligible for CPR, but at least listen from the patient. Okay, guys. So step 6 here, care after this. Recognition, we finished already. So support for carers and families in all steps. Information for patients and carers in all steps. Spiritual care services. So end of life in advanced kidney disease. So advanced kidney disease, you have, we mentioned already, 3 options. What are the 3 options, guys?
Dialysis, conservative, and transplantation.
Yeah. So we will start by conservative because it's a conservative kidney management, maybe dialysis, maybe transplantation. So conservative here, recognition of end of life care, whatever conservative or dialysis or transplantation. So you have to recognize end of life care needs and last days of life. So if conservative, so patients who choose not to dialysis, patients who choose not to dialysis. So you will ask the patient, you have 3 options. If the patient has option only for dialysis, don't give him options. Okay. So just tell him you need dialysis. Don't tell him you need dialysis, transplantation, or conservative management. No. But if the patient eligible for conservative management, eligible for dialysis, eligible for transplantation, you can give him 3 options. So honestly here, you can give clear and honest options. So I want to do conservative if the patient doesn't want dialysis. You give him 3 options, but he doesn't want dialysis. Receive all other aspects of kidney care. Pathway starts at time when dialysis would have started. So may depend on the patient's circumstance. Kidney end of life care. All patients approaching end of life, regardless of modality of treatment, able to access both kidney and supportive care service, a strong and seamless links with primary, community, and palliative care services. Deteriorating despite dialysis, failing transplant, not returning to dialysis. So schematic model for end-of-life care in advanced kidney disease. We are talking about end-of-life care in advanced kidney disease. So which patients who needs advanced kidney care? So patients who are recognized to be approaching the phase of end of life, Patients may be on dialysis with a transplant or receiving conservative kidney management. In some patients, dialysis may be discontinued. Others may opt to continue this treatment. What should the service provide? So, symptomatic, supportive, and palliative care. Teamwork should involve close communication and support from palliative and primary care teams. Preparation for this place of care discussion with patient and carers, ensuring advice and help. Available at all times from knowledgeable member of renal team. Coordination of physical, psychological, and spiritual care by joint working with primary, community, and secondary care services. Care and support after this for carers and families. So, what about the team? Who should be in the team? Every renal unit should have lead clinician for kidney end-of-life care. The role of the key worker with responsibility for coordinating the end-of-life care for an individual patient should be developed. Links with all subspecialties areas of the unit, like for example, you have contact with dialysis unit, transplant unit, and the nephrology clinics should be developed, perhaps through system of link nurses who work in these areas but have received specific training and liaise with kidney end-of-life care lead the key workers. A strong link with palliative care teams and the primary care are needed. So what about conservative? So which patients? As we said, patients who decide against starting dialysis, patient usually commences this pathway at the time they would otherwise have commenced dialysis. So conservative kidney management, you have to be familiar about which patients and the service involved what, and the team for conservative. Okay, so regarding the service, any patient you decide, you and the patient, you decide to take conservative kidney management. So here you have to agree a plan regarding the service. So all aspects of care apart from dialysis means any patient with end organ failure kidney disease and already is on conservative, so you will provide him each care except dialysis. Patients are usually frail and often elderly. Care should be as close to home as possible. Unnecessary hospital visits should be avoided. So it means if not necessary to go hospital, don't ask the patient you can go hospital. Strong links with primary community care. Services are needed. Many patients have other significant comorbidities. The renal team may only be advisory. Patients and carers should have easy access to the renal team, so you can guide the patient how to access the renal team, how to contact the renal team, and also you as a carer. So you and the patient and the carer. So three, you have to be in contact with the renal team. Team member who understands an individual patient's situation should be easily contactable. Specialist palliative care for difficult symptoms, complex psychological care, and terminal care were needed. So you have to agree a plan regarding the service. And also who involved regarding the team. So patients should be able to access all relevant members of multidisciplinary team, which is usually led by nephrologist and or specialist nurse. A key worker should be named for each patient. So each patient, he has key worker. and by name, ensuring that coordination of care is provided. Dietetic anemia, social work, psychological, spiritual care should be provided. Integration with primary care and community nursing services is essential, as is access to specialist palliative care. Teamwork and good communication are essential to ensure patients and carers have access to personalized advice and support when they need it. Records and communication should be constructed so that 24 hours a day service is available in case of crisis. So, as we discussed earlier, you have to expect the symptoms of the patient who is going to die within 12 months, whatever, 1 hour, 1 day, 1 month, 12 months, or more. So people in the last days and the hours of life may experience a spectrum of distressing physical symptoms. Already the patient, he knows he will die. Okay, so he is in pain, nausea, agitation, delirium, anxiety, and or respiratory tract secretions. Consider involving patients and relatives in discussions early. Reversible causes of symptoms and the non-pharmacological approaches. So repositioning for respiratory secretion. So despite to give the patient medicine, you can do non-pharmacological approaches first. For example, repositioning for respiratory secretions. Stop any medications that have no benefits and switch essential medications to non-oral routes. So subcutaneous infusion if the patient is unable to swallow. For pain and or breathlessness, so morphine, here you can give 2.55 milligram hourly subcutaneous PRN. For anxiety, agitation, seizures, so midazolam 2.5 up to 5 milligram hourly sub-Q PRN. For nausea, vomiting, hallucination, so you can use levomethazine 2.5 up to 5 milligram for hourly sub-Q. For respiratory secretions, glycopyrronium 400 microgram for hourly, maximum 1.2 milligram 24 hours. Remember, so this advice, it can be a question. Use lowest effective dose, reduce opiate dose. So frequency here in end-stage renal failure, very frail or low weight. So in these cases, you can reduce opiate dose. Consider increased PRN doses in patients taking regular opiates. So complete local drug authorization and controlled drug prescription for discharge. You can check this website. Pain management. So condition number 4, we will talk about pain management and then other symptoms management. So what is the first action? NICE guidelines offer the following guidance on using opioid for pain relief in palliative care. So first, start by strong opioids, titrating the dose. When starting treatment with strong opioid, offer patients with advanced and progressive disease regular oral sustained release. Remember that it can be a question, or oral immediate release morphine, depending on patient preference, with rescue doses of oral immediate release morphine for breakthrough pain. Remember that. For patients with no renal or hepatic comorbidities, so this patient is going to die within 12 months, but he doesn't have a liver or kidney problem. Offer typical total daily starting dose schedule. You can start by 20 to 30 milligram of oral morphine. For example, 10 to 15 milligram oral sustained release, Okay, twice daily, plus 5 milligram oral immediate release morphine for rescue doses during the titration phase. Adjust the dose until good balance exists between acceptable pain control and side effects. If this balance is not reached after few dose adjustment, seek specialist advice. Offer patients frequent review, particularly in the titration phase. So you will give him and assess the pain if you still have pain, so you can titrate. Seek specialist advice before prescribing strong opioid for patient with moderate to severe renal or hepatic impairment. So any patient with renal or liver problem, so seek specialist advice. What about maintenance? We talk about rescue doses. Okay. So maintenance here, offer oral sustained release morphine as first line maintenance treatment to patients with advanced and progressive disease who require strong opioids. Don't routinely offer transdermal patch formulations as first line maintenance. Remember that. It can be questioned to patients in whom oral opioids are suitable. If pain remains inadequately controlled despite optimizing first line maintenance treatment, review analgesic strategy and consider seeking specialist advice. So first line treatment for breakthrough pain, offer oral immediate release morphine for first line rescue medication of breakthrough pain in patients on maintenance oral morphine treatment. Don't offer fast acting fentanyl as first line rescue medication. Remember that, don't offer fast-acting fentanyl as first-line rescue medication. If pain remains inadequately controlled despite optimizing treatment, consider seeking specialist advice. What about transdermal patches and subcutaneous delivery? So consider initiating transdermal patches with the lowest acquisition cost for patients in whom oral opioids are not suitable and analgesic requirements are stable, supported by specialist advice where needed. Consider initiating subcutaneous opioid with the lowest acquisition cost for patients in whom oral opioids are not suitable and the analgesic requirements are unstable, supported by specialist advice where needed. So again, physical symptoms, condition number 5, other than pain, it means nausea, vomiting, plus minus vertigo, breathlessness, anxiety, distress, delirium, agitation, noisy chest secretion, massive hemorrhage, seizures. The most common, nausea, vomiting, vertigo, and breathlessness. So regarding nausea, vomiting, NICE here recommend use of octreotide for people in the last days of life with obstructive bowel disorders who have nausea or vomiting. So if they mention in the scenario and you understand the patient is going to die and he has nausea, vomiting, so if you find the option of octreotide, you can choose, especially if the patient has obstructive bowel disorder. If the symptoms don't improve within 24 hours of starting treatment with hyoscine, so the first action is hyoscine, and if not responding, you will use octreotide. NICE offers the following guidance when managing nausea, vomiting in the last days of life. Assess for likely causes of nausea or vomiting in the dying person. So maybe because of medicine, the patient has polypharmacy. So maybe he has nausea and vomiting because of other medicine, certain medicines that can cause or contribute to nausea and vomiting. Recent chemotherapy or radiotherapy. So you should check the scenario if the patient has chemotherapy or radiotherapy. Maybe this is the reason. Psychological causes. Sometimes because of stress, the patient has nausea, vomiting. Biochemical causes, hypercalcemia, because what is the most first common cause of hypercalcemia?
Hyperparathyroidism.
Primary
Primary
hyperparathyroidism.
hyperparathyroidism.
Parathyroidism. And what is the second
Primary
most common?
Malignancy.
Malignancy.
So any patient with advanced malignancy and he is going to die within 12 months, so you can expect hypercalcemia. You can expect nausea vomiting because of hypercalcemia. What else for hypercalcemia? Symptoms in general.
Stones, bones,
Sickness.
bone.
I'm talking about sickness, confusion, and
Agitation, delirium.
also polyuria, polydipsia, and so on. Raised intracranial pressure. So maybe the patient has metastasis in the brain and he has nausea vomiting because of raised intracranial pressure. Gastrointestinal motility disorder. Maybe he has ileus or bowel obstruction. So discuss the options for treating nausea and vomiting with the dying person and those important to them. So you will discuss the options here before nausea and vomiting or after nausea and vomiting or both?
Before.
Before and after. So you are asking the patient, if you will get nausea vomiting, we have treatment like blah, 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 blah. And if the patient get nausea vomiting, you can discuss with him again. So consider non-pharmacological methods for treating nausea and vomiting in a person in the last days of life. When choosing medicine to manage nausea or vomiting in a person in the last days of life, take into account the likely cause, as we said, maybe it's a reversible cause, side effects, including sedative effects of the medicine, other symptoms the person has. So patient has nausea, vomiting, you can check he has other symptoms or not. The desired balancing of effects when managing other symptoms, compatibility and the drug interactions with other medicines the person is taking. So consider these points. For people in the last days of life with obstructive bowel disorder who have nausea or vomiting, so consider first hyoscine bromide as the first line, as we mentioned, and then torotide if the symptoms don't improve. Remember that within 24 hours of starting hyoscine. Nausea and vomiting. So if the patient has nausea and vomiting only, and the patient has nausea and vomiting with other symptoms, it's a different. The treatment here will be different. So if the patient has nausea, vomiting, and vertigo, so what is the treatment?
Cyclizine.
Cyclizine. Okay. If the patient has vertigo and the nausea, vomiting, cyclizine has antihistamine properties, will help symptoms of vertigo. Ondansetron, this one specific 5-HT antagonist, useful when patient receiving cytotoxic treatment. So the patient has nausea, vomiting because he's using in the scenario any drugs or any treatment for cytotoxic treatment. So you will use ondansetron. If the patient using any treatment or you have suspicion of cytotoxic treatment, so you can use also domperidone. Okay. If the patient has nausea, vomiting because he has a gastroduodenal or hepatic or biliary disease, what is the treatment?
Metoclopramide.
Metoclopramide.
Yes. So haloperidol can be useful in terminal care where other agents have not been successful. So here, if the patient not improve on other medicines, so you can use haloperidol. Breathlessness. So NICE here has guidance regarding breathlessness in the last days of life. Identify and treat reversible causes of breathlessness. So maybe the patient has breathlessness, of course, apart from stress, apart from psychological. So you can think about something serious, pulmonary edema, pulmonary effusion. So it's reversible causes. You can treat them, treat the underlying cause. Consider non-pharmacological management of breathlessness in a person in the last days of life. Don't routinely start oxygen. remember that the patient is dying phase, so don't routinely start oxygen to manage breathlessness. Only offer oxygen therapy to people known or clinically suspected to have symptomatic hypoxemia. It means the patient has hypoxia, but he doesn't have symptoms. So it's not a big issue if you will not give him oxygen. But here, only offer oxygen therapy to people known or clinically suspected to have symptomatic hypoxemia. Consider managing breathlessness. Opioid, you can give opioid. If you find in the scenario option of opioid, you can choose. Benzodiazepine, you can choose. Combination of opioid and benzodiazepine, both of them also can be considered. Condition number 6, psychosocial concerns, including spiritual care and care of the family. So malignancy, if you explain to the patient that it is in his best interest to be referred to a specialist, but he declined. So the patient in advanced age and advanced case, advanced stage, and he doesn't know that he have malignancy. He doesn't know that he will die within the next 12 months. So you explain to him this in his best interest to be referred to a specialist, but he declines. What he will do? He also doesn't want the information passed on to his family. He will tell you, no, I don't want to go to a specialist or refer to a specialist, and don't inform my family. He has also stated that he doesn't want to hear any bad news. He doesn't want you to continue. Okay, this can happen in practice. The patient, old age, and he came to you with advanced stage, but he's talking, he can understand, he has capacity. Okay, so you ask him this blah 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 blah. You are honest with him and you explain to him everything, and he is refusing to be referred. He is refusing to inform his family. He is refusing you to continue explanation. And when you explain to any patient, guys, explain piece by piece. Why? Because each piece needs consent. Remember that each piece of information needs consent. For example, I'm sorry to tell you that you have blah, blah, blah. Would you like me to explain more? Maybe he will say no. So don't be talkative to the patient. Give him 15 minutes communication without listening to him, without explaining to him, without checking understanding, without consent. No, always give piece by piece. And this will be helpful in OSCE exam. Okay, so always, if you give the patient piece of information, is that clear for you? Did you understand? After that, would you like me to explain more? If he said yes, continue. After you continue, ask him again. Did you understand? After that, would you like me to explain more? Yes. So at any stage, check understanding and check he is happy to continue or not. Okay. So what you will do, if you have scenario like that, whatever refuse to be referred, whatever refuse to inform his family, whatever refuse to continue pieces of information. So what is the option in the scenario? You assess his mental capacity. So if you find this option in the scenario, choose. You assess his mental capacity, and if deemed competent and have capacity, what you will do? Respect his decision. You should document that the patient has declined information. So what if the patient doesn't have capacity, guys? What you will do?
Check for AD or
Okay, so the patient came to you today and he doesn't have any problem before and already diagnosed with advanced stage, okay? So here you assess his mental capacity, and if he has capacity, means competent, okay? So you have to respect his decision, and you should document that the patient has declined information. There is no indication for an independent psychiatric review of this patient, but it should be clearly documented. Okay, there is no indication, remember that, for an independent psychiatric review of this patient, but it should be clearly documented in his notes that you have assessed his mental capacity, determined that he is competent to make decisions. It can be inappropriate. How to understand this patient is competent, guys? What is the difference between competency and have capacity? Why is they said here competent and have capacity? What is the difference between them? Any idea?
No.
Okay, so when to say this patient is competent or this person is competent, what is the criteria to be valid?
So when he is not intoxicated and when he is not having any mental health illness at that point.
Okay,
His cognition.
cognition, excellent, cognition. Okay, so first of all, the patient is adult, more than 18. Okay, the patient or the person to be competent, he should be adult, more than 18. Any patient or any person, there is presumption of competency more than 16. Okay, but here competent, you have to check cognition. Okay, if the patient has no cognition or impaired cognition, can you assess his capacity?
No.
No.
So first of all, cognition. That's why you have 4 points in any patient in psychiatry. It will be helpful in OSCE. So first of all, check cognition. Okay, cognition, and then questions of depression, and then questions of psychosis, and then question of self-harm. So in the end, you can assess his capacity. The capacity here is the last step. Okay, so if the patient is competent, it means he has cognition, means oriented to time, oriented to place, oriented to also the person, and he can follow your commands, he can follow everything, and he's adult as well, and is conscious. Okay, so there is no indication already, we mentioned that. It would be inappropriate in this case to refer him to specialist against his wishes. It means if he has capacity and he doesn't want to be referred, don't refer. Or to breach confidentiality. He doesn't want to inform his family, so don't breach confidentiality here. And discuss his illness with his next kin or family. Okay. The JMC guidelines states that the fact that a patient has declined relevant information should be documented. It is inappropriate to apply pressure to a patient to change their mind in these circumstances. So don't insist on the patient, don't force him to accept, okay? So inappropriate to do that. Breaking bad news. So psychosocial concern, including spiritual care and care of the family. So breaking bad news here to the patient and to the family. And of course, if you will break the news to the family, of course, after consent from
From the patient.
Patient.
From the patient himself.
Okay, so the family in this situation, it means already we took consent from the patient. The family in this situation are acting in good faith. They seek to protect their loved one from anguish of knowing the nature of their underlying condition. However, if the patient has mental capacity, the nature of their condition should be explained to them if they desire to be. Have a frank but sensitive discussion with them about this and take time to explore. Don't be in a hurry. Give them peace and stop. they will swallow this piece and check understanding. Ask them, would you like me to explore more? Yeah, and so on. So what you will do with the patient, do with the relative as well. Okay, always like that, breaking bad news, communication skills. So give piece by piece and check understanding and take consent for the second piece, take consent for the third piece, and so on. Would you like me to explain more? And so on. How much information she would like to know about her condition. And also the patient. For example, maybe the patient already want to know more. So at the middle of the conversation, maybe he cannot accept more information. So he will tell you, okay, it's enough. Please stop. So you have to stop. Okay. So at any stage, the patient will stop you, stop. At any stage, the relative will stop you, stop. Provide the following guidance on supporting hydration in the last days of life. So condition number 7, the dying patient. The dying patient here may be in the hospital. So as we said earlier, it depends on the patient. Maybe the patient want to die at home. Maybe he want to die in a special city or in special country. So it depends on the patient preference. So support the dying person to drink if they wish to and are able to. So rehydration here, it's very, very important. So the Royal College care about pain management, other symptoms management, and rehydration of the patient. Okay, support the dying person to drink if they wish to and are able to. Check for any difficulties such as swallowing. So it's a very common complication, difficulty of swallowing. So if the patient has difficulty of swallowing, don't give him oral. Check for any difficulties such as swallowing problems or risk of aspiration. Discuss the risks and the benefits of continuing to drink. So before rehydrating the patient, explain to him the risk and the benefits of that with the dying person and those involved in the dying person's care. So you can explain to the patient and the carer as well. Offer frequent care of the mouse. So always rehydrate the mouse even he is not drinking and the lips to the dying person and include management of dry mouth in their care plan if needed. Offer the person the following: help with cleaning their teeth or dentures if they would like, frequent sips of fluid, encourage people important to the dying person to help with mouth and lip care. So you explain to the family and carer to care about the mouth and lips or giving drinks. Provide any necessary aids and give them advice on giving drinks safely. Assess, preferably, daily the dying person's hydration status. So you will check the in and the out of hydration and review the possible need for starting clinically assisted hydration, respecting the person's wishes and preference. Discuss the risks and benefits of clinically assisted hydration with the dying person and those important to them. Advise them that for someone who is in the last days of life, clinically assisted hydration may relieve distressing symptoms. So why the Royal College care about hydration? Because it will relieve distressing symptoms or signs related to the hydration, but may cause other problems. So take care. Hydration here may be overfluids. So avoid overfluids. It is uncertain if giving clinically assisted hydration will prolong life or extend the dying process. Uncertain if not giving clinically assisted hydration will hasten death. Ensure that any concerns raised by the dying person or those important to them are addressed before starting clinically assisted hydration. So you should examine and assist the patient before hydrating. When considering clinically assisted hydration for a dying person, use an individualized approach and take into account whether they have expressed a preference for or against clinically assisted hydration, or have any cultural, spiritual, or religious beliefs that might affect this documented in advance statement or advance decision to refuse treatment. So you will document their level of consciousness, any swallowing difficulties, their level of thirst, the risk of pulmonary edema, whether even temporary recovery is possible. So before doing assisted hydration, consider these factors. Consider therapeutic trial of clinically assisted hydration if the person has distressing symptoms. So he want to start that, or he want to start early that if the patient has distressing symptoms or signs that could be associated with the hydration. So if the patient has thirsty, delirium, and oral hydration is inadequate. So at that time, you can go for clinically assisted hydration. For people being started on clinically assisted hydration, monitor at least every 12 hours for changes in the symptoms and the signs of dehydration, and for any evidence of benefit or harm. So within 12 hours, check the patient is still dehydrated, if the patient is rehydrated, if the patient is fluid overload. Continuous clinically assisted hydration if there are signs of clinical benefit. So if the patient get benefit, you can continue. If the patient is not getting benefit, you can reduce or stop clinically assisted hydration if there are signs of possible harm to the dying person, such as fluid overload. For people already dependent on clinically assisted hydration, whatever enteral or parenteral, before the last days of life, it means they are already on clinically assisted hydration for a long time. So review the risk and benefit of continuing clinically assisted hydration with the person and those important to them. Consider whether to continue, reduce, or stop clinically assisted hydration as the person nears this. Okay, what is the single most likely diagnosis?
Esophageal cardiac.
Esophageal candidiasis.
Excellent. Esophageal candidiasis. So the patient is old and recently received the treatment for lymphoma. So once you see all the patient and he's talking about advanced stage, so your retrosternal pain and the dysphagia and difficulty in swallowing, so it's esophageal candidiasis. And here also they said she only has a few months to live. It means advanced. Patient is going to die. Which of the following?
Oral fluconazole.
Excellent. Oral fluconazole. Okay. Most suitable next statement.
Qutipin,
Amitriptyline.
fentanyl,
Amitriptyline.
Okay. This was the patient has neuropathic pain. Following is most suitable next treatment for this patient.
Gabapentin.
Gabapentin.
Okay. True regarding advanced decision.
First one.
Yeah, first one.
Okay. So you have four statement. So second one is CPR. Third one is
IV fluids, hydration.
okay. Fourth.
Special procedure.
Okay. Single statement is true regarding advanced decision.
Third one. Make decision about the use of IV fluids.
Okay. Okay. Which one of the following would be most appropriate course of action?
Second opinion should be sought to resolve this disagreement.
Option?
4.
Okay, second opinion should be sought to resolve this disagreement. So when you are studying, guys, study the question also. Sometimes the question knowledgeable. So you can read the question, you will understand many points. It will help you in the exam. When you are reading any question in general, you can use the question. It's not about the answer. Okay. Which of the following is recommended by NICE as first line risk?
Subcutaneous morphine.
Subcutaneous morphine. Oh, okay.
Immediate release.
Oral immediate release morphine.
Yeah, okay.
Which of the following is recommended by NICE as first line risk?
Sustained release.
He is currently taking 15 milligrams.
Oral immediate release morphine.
Immediate release.
Okay. Which of the following is the most appropriate starting dose?
Last option.
20 to 30 milligram
30.
morphine daily in divided doses. Yeah,
Yes.
first option.
Most appropriate starting dose schedule?
Fifteen mg oral sustained release morphine twice daily.
Okay. Which of the following is the most appropriate management at this stage?
Sustained release oral morphine.
Sustained release oral morphine. Most appropriate treatment to manage hair, nausea, and vomiting?
Prochlorperazine.
Hyoscine.
Hyoscine butyl bromide.
Hyoscine, the
Hyoscine.
first line. Okay. First line. Okay. Most appropriate treatment?
Cyclizine.
Cyclizine.
Octreotide.
Why? Because
Bowel
already
obstruction.
hyoscine given, but no improvement. Okay. Why you said cyclizine? Any vertigo here?
No.
For bowel obstruction, I think octreotide.
Yes, but the first line is hyoscine, and in attempt to manage her symptom, but no improvement. So the second option is octreotide. Single most suitable antiemetic to prescribe for this patient. He has nausea.
Cyclizine.
Cyclazine.
Because
Cyclizine.
vertigo is there. Yeah.
Okay. Most appropriate treatment, breathlessness.
Oral morphine.
Oral morphine.
Oral morphine, okay. Most appropriate treatment to manage breathlessness.
Diazepam.
Diazepam.
Okay, diazepam. True regarding ongoing care.
You should document that the patient has declined information. Option C.
Okay, you should document that the patient has declined information. Okay, so here he said mental capacity, and already after assessing mental capacity, he is competent and have capacity, so you should respect his decision and document that the patient declined information. Most appropriate way forward. The family don't want you to tell the patient. She would not want to know.
Last option.
Yes. So inform families that whilst you sympathize with their point of view, you cannot withhold this information from the patient. You have to be honest with the patient and clear with the patient. You'd like to speak with her to explore how much information she'd like to know. Which of the following is the most appropriate management?
Encourage frequency of
Fluids.
Encourage frequent sips of fluids.
Fluid.
Okay.
option E.
Okay. Encourage frequent sips of fluids. Thank you, guys. very short session and very short chapter. Inshallah, tomorrow in the same time, and I will continue to post more questions. Inshallah, today I am free. Today
Thank you, Dr. Hani. Thank
I
you.
will post almost 100 questions. Inshallah, today. Okay. Bye bye.
Thank you.
Bye bye.
Next session is what, Dr. Hani?
Tomorrow, 1 to 3.
The name يعني of the chapter.
We are following the curriculum. You can check the curriculum. Okay.
Okay. Okay. Thank you.
We are going in arrangements. Thank you. Bye.